The official program of this conference mentions the following question as the title of my contribution. What does autonomy mean for medical professionals working with persons with psychosocial disabilities? I have translated this question into the title you can read on this slide, which expresses an answer direction and a challenge at the same time. The title also makes clear that my focus will be on an extremely relevant and large group of vulnerable people, namely the group of mainly adult persons suffering from cognitive impairment and decision-making disability due to Alzheimer's disease and related disorders. My goal is to stipulate the ethical and practical implications of an inclusionary approach to decisional capacity. To that end, I will first briefly summarize the key elements of this approach and its background in moral philosophy and human rights treaties. And next, I will go into the hazards of this approach, the risk of overestimating a person's capacity on the one hand, and the reverse risk of underestimating a person's capacity on the other. I will do so by presenting two case vignettes that, as a typical example, are both related to advanced directives. Finally, I will reflect on the notion of authenticity and its relevance or irrelevance for judging the moral soundness of specific decisions in terms of, is this decision to be respected and supported as being truly mine from the patient's perspective? I offer no definite answers, but hopefully some food for discussion and further reflection. Now, during the past decades, our approach to capacity has shifted from viewing capacity as a categorical all or nothing phenomenon towards a task-related concept. In clinical practice, the capacity issue is typically raised when a patient opts for a course of action or makes a decision that causes the clinician to think, is this decision really good enough? As part of the answer to this question, a capacity assessment might take place, which will focus on the quality of the decision-making abilities of the person in question. Some say that this is a value-free judgment because it only looks at the relevant mental functioning. But in practice, there is always a relation to the potential outcome of the decision and whether we see this as a good outcome or not. And this is where values come into play, and thus the assessment always has an ethical dimension. In addition, the aim of the assessment is still to judge whether a person can decide for herself, with as a possible drastic outcome that others should decide for her. In this sense, capacity assessments are potentially still exclusionary. Research, however, indicates that clinicians feel uneasy with this approach and frequently shy away from formal capacity assessments. Nonetheless, from the perspective of medical ethics, capacity defined as the ability to make one's own decisions is a crucial element of informed consent. And that is because a consent to care plans or medical treatments is not valid if it is not voluntary, and it is not voluntary if there are external constraints, such as a lack of information or the use of coercion, of pressure, nor is it voluntary in case of internal constraints, such as impaired decision-making ability. And this is where capacity comes into play. In view of the current approach to capacity, its place in medical ethics, and the potential negative consequences of a formal capacity assessment, members of the IPA Capacity Task Force, including myself, have made a plea to move away from an exclusionary concept towards a more dimensional and inclusionary concept of capacity. One of the fundamental ideas underlying this alternative is that capacity assessments should primarily be undertaken not to judge whether people are capable or not to make specified decisions, but rather to assess what kind of support people with decision-making disabilities need in order to be involved in relevant decision-making. This paradigm shift has been heralded by a number of human rights frameworks, such as the European Convention on Human Rights and the United Nations Convention on the Rights of People with Disabilities. Importantly, Article 12 of this UN Convention specifically states that professionals must take appropriate measures to provide access by persons with disabilities to the support they may require in exercising their legal capacity. Thus, this UN treaty intends to mark a shift away from substituted decision-making towards supported decision-making. This calls for adequate models of supported decision-making, but also, and importantly, for more nuanced approaches to autonomy as a response to the dominant right-based concept. From a philosophical perspective, the traditional and the inclusionary approach to capacity can be related to two different models of autonomy. The exclusionary approach aligns with a defensive concept of autonomy, also known as negative freedom. Central here is the principle of non-interference. Respect for autonomy, according to this principle, means offering people the opportunity for self-governance unless they lack capacity. The fact, however, is that people are not born as self-governing and self-sufficient individuals. One can even say that this abstract ideal reflects the human condition only in a very distorted way. Certainly in caregiving relations, the relevance of a second, more relational and developmental meaning of autonomy becomes clear. According to this concept, autonomy also refers to living life according to standards we can call our own. But because we don't live our lives isolated from the world and its uncertainties, these standards are never fixed. We regularly need to adapt and identify ourselves with changing life circumstances, such as illness and other relevant life events. And to succeed here, we are in need of support from others. While the first concept of autonomy aligns with autonomous decision-making, the second calls for more relational approaches, such as collaborative decision-making. However, before explaining this model in more detail, I would like to add a few more thoughts on the concept of capacity. In my opinion, I think it is relevant to emphasize that capacity in the real world is wider than the concept as defined in the Medical Capacity Act and related statutory definitions, in which the full accent is on the dimension of understanding. Understanding means that a patient knows that he or she is consenting to an intervention and what this intervention involves. This component of capacity has been successfully operationalized in the widely used criteria of Applebaum and Grisot that focus on recall, handling and weighing of information, and on expressing a choice. However, there is more to capacity than just understanding. Essentially, capacity invokes the notion of ability, and this in turn involves something very practical, something that has to do with agency and knowing how to act in the world. And here I would like to quote Julian Hughes, where he says, "To have capacity is to have the ability to participate in the relevant and particular sphere of facts and value-laden acts of the human world." On the basis of this broader concept, we need to distinguish two other components of decisional capacity, namely intentionality and voluntariness. Intentionality means willed in accordance with a plan, and in the clinical setting, this translates into the making and implementing of care plans, according to mutually agreed upon goals of care. These goals involve health-related goals as well as personal goals of the patient. Therefore, decision-making is not an event, but an ongoing process. If a patient understands and agrees to a plan of care, but isn't able to cooperate in carrying out his plan, this impairment in intentionality is of ethical significance and should lead us not only to ask whether the patient needs specific support, but perhaps also whether we have chosen the right course of action in pursuing this plan. Intentionality, more than understanding, presupposes relative intact executive control functions. The same holds for the component of voluntariness. As said, Informed consent is invalid when it is not given freely and voluntarily. Voluntariness can be impaired if a patient suffers from severe depression or psychosis. These illnesses can be seen as internal impediments to voluntariness. But voluntariness can also be impaired externally by exerting pressure or by manipulating a patient. This can happen to patients suffering from severe psychiatric illnesses, such as the ones just mentioned, but also patients with impaired executive control function are vulnerable to such manipulation, as they are frequently dependent on appropriate verbal and behavioral cues from their environment. Thus, they are in danger of being controlled by others and to have their preferences overridden by the preferences of others. A scrupulous approach, inclusionary approach to decision-making, therefore calls for the framework of collaborative decision-making. Collaborative decision-making is an alternative, or better, a further development of the popular model of shared decision-making. The essential difference between both models is that collaborative decision-making is not seen that in collaborative decision-making is not seen as an event, but as an ongoing process, allowing the participation of more participants. The focus is on jointly constructing a care plan and on carrying out this plan. The latter is important because decision-making is the starting point of the development of a care plan that needs to be executed over time in a care process, and that calls for further decision-making and ongoing commitment from all parties involved. In addition, a truly collaborative approach underscores the relevance of a wider non-medical context of patient values. Assisting patients to elaborate on what they consider of relevance in their life can be seen as an enabling approach to decision-making. Thus, one seeks to compensate cognitive limitation by addressing individual strengths. Building on a developmental concept of autonomy and on the principles of collaborative decision-making outlined very briefly here, we, that is to say the IPA task force, stipulated the following stepwise approach to supportive decision-making summarized in the acronym ASK-ME. First, assess where strengths and limitations lie, and consequently, indulge in the person's awareness of a situation. Secondly, tailor and simplify the task to the specific decision at hand. Next, know the patient, that is to say, find out what he considers of relevance in his life, what his long-held values are, and how they pertain to the decision at hand. Next, maximize participation by addressing strengths and providing aids, and by doing so, enable participation by tailoring the degree of support to the complexity of the decision and the seriousness of the consequences. Importantly, the essence of collaboration is to find a common ground for working together, and the effect of this stepwise approach might be that the problem to be decided on is rephrased or reframed during the process and the execution of the care plan. And this brings me to the second topic of this talk. The greatest challenge to an inclusionary approach to capacity health professionals face is that they have to attune to the level of awareness of the person with decision-making disabilities, such as persons with dementia. This is, in a way, what competent caregivers, professionals, and family caregivers do every day. It is an essential prerequisite for caregiving and continuity in the care process. Collaboration calls for what is defined to be an important principle of person-centered care for people with dementia. Try to step in their shoes and to see the world through their eyes. This implies nothing less than choosing the patient's subjective awareness to be the starting point of the caregiving process. This requires high-quality communicative skills, attentive listening, and responsivity in order not to overrule the patient and to encourage partnership as much as possible. And so this is where we come to the two hazards we need to be attentive to, the one of overestimating capacity and the reverse risk of underestimating capacity. Both risks become especially salient in patients with advanced directives, and to illustrate this, I will now present two case vignettes, the case of Anne and the case of Louise. After her husband died in a car accident, Anne never remarried, and she raised her children with the support of her older sister. After she died with dementia some 10 years ago, Anne drafted a non-treatment advance directive meant for the situation of being diagnosed with dementia. She also named her daughter and son as authorized representatives. Now, Anne has been a smoker all of her life, and she suffers from COPD with recurrent exacerbations. 4 years ago, she was herself also diagnosed with dementia, and recently her children had to move her to a nursing home. They felt guilty in doing so, but much to their surprise, Anne felt quite at home here, and she soon made good contacts with other residents. Several months later, she contracts a lower respiratory tract infection. She feels very ill and suffers from a severe cough and shortness of breath. Upon arrival of the physician, and even before being asked, she urgently requests the doctor, "Please, make me feel better again." The physician, after physical examination, informs Anne and her children of his findings and proposes a treatment with antibiotics. Without hesitation, Anne consents to this proposal, but her children are very confused because of Anne's advance directive, a directive that more or less forbids treatment with antibiotics. The question is what to do, how to involve Anne in the decision-making process, or do we follow her advance directive? We'll get back to this question after having introduced the case of Louise. Louise is married to Thomas. She is a very warm person, but also shy and withdrawn, and she has lived all of her life in the shadow of her very dominant husband. Thomas is a former CEO of a large company, and he is used to have things done his way. In his public as well as in his private life, he is the one who takes all the decisions. This attitude resulted in a tense relation with the couple's only daughter, who eventually stopped seeing her father, but continued to have warm contacts with her mother, though at some distance. When his brother died of Alzheimer's disease in a nursing home, Thomas drafted an advance directive for himself and an advance directive for his wife, in which he refused nursing home placement and medical treatment in case he or Louise was to be diagnosed with dementia. He told Louise to sign the document, which she did, obedient to Thomas' will. Over the years, Louise suffered several minor subcortical strokes, and she became progressively inactive, depressed, and apathetic. This behavior worried and also irritated Thomas. In addition, Anne also developed swallowing problems with recurrent aspiration. On Thomas' request, she was now referred to a geriatrician who diagnosed her with vascular dementia. This diagnosis came as a huge shock to Thomas. He knew what Alzheimer's could be like, but this was quite a different illness, although equally debilitating. Several months later, Louise was hospitalized with a severe aspiration pneumonia, and the treatment with antibiotics, cortisone, and oxygen was started. Thomas, however, after some reflection, urges the doctor to discontinue treatment, referring to his wife's advance directive. When asked by the physician, with her husband present, Louise confirms Thomas' opinion and reaffirms the advance directive read to her by her husband. However, to the nurses and to her daughter, she is much more hesitant, and she expresses herself more positively towards treatment continuation. Also here, the question is raised, what to do? Is Louise capable to participate in the decision-making process, or is she too ill or too impressionable to be involved? In stipulating how one might answer these questions in both cases, I will restrict myself here to the first and the third element of the Ask Me approach, as they seem to be most crucial here. Now, in Anne's case, it seems clear that she has capacity regarding all three dimensions. She understands what's wrong with her. She knows that the information given to her applies to her current situation. She produces recognizable reasons in consenting to treatment and appears able to cooperate voluntarily, for not only does she express a clear wish, she does so spontaneously. We can understand why she chooses as she chooses because of her memory impairments. Difficulties in laying down new episodic memories may prevent her from updating her self-concept, and similarly, poorer autobiographical recall may also explain why Anne holds on to former preferences, because in her current situation, she is, in her experience, still the same person, while to the outside world, she is in a state of progressive dementia. In terms of the Ask Me approach, all steps can be made without problem, except for step 3, because respecting Anne's current choice seems to run counter to her preferences as expressed in the living will. Louise's case is almost opposite to Anne's. She does not express a clear choice, and so far we are ill-informed about her capacity to understand, recall, and weigh information. That is to say, her level of functioning regarding the first dimension of capacity. But it does seem pretty clear that she has impaired intentionality and voluntariness. Key to Louise's decision-making disability is impaired executive functioning, and she will need very careful and incoercive cueing in order to be able, if at all possible, to participate in decision-making and in carrying out a care plan. But with proper support, chances are fair that she will choose in favor of treatment. But here again, step 3 in the Ask Me approach seems most problematic. So the question is, are we overestimating Anne's capacity by not bringing the advance directive to the decision-making process? And conversely, are we not underestimating Louise's capacity by not acting in accordance to her advance directive, which she confirms in the presence of her husband? Perhaps my final topic, the notion of authenticity and of authentic choice, can be of any assistance here. According to the contemporary philosopher Charles Taylor, the so-called ethic of authenticity is something relatively new, but very peculiar and typical to our Western culture. According to Taylor, this is the moral background of modern slogans like live life your own way and do your own thing. The notion of authenticity traces back to the end of the 18th century and finds its first paradigmatic formulation in the works of Jean-Paul Rousseau. The central theme of an ethic of authenticity is that as humans, we have to be truthful to ourselves. That is to say, in being true to myself, I have to be true to my inner self, my originality, and my deepest beliefs, whatever they may be. It derives from this moral ideal that an authentic choice would be a choice that is in accordance with what we regularly name our long-held values, or in Ronald Dworkin's words, our critical interests. Applied to the cases of Anne and Louise, we might say that respecting their current choice would be respecting a choice that lacks authenticity. Anne is not truthful to herself if we accept that she expressed this true self, long-held values, and critical interests in the living will. And neither is Louise when she consents to medical treatment. However, I tend to agree with Charles Taylor, where he argues that an ethic of authenticity is inconsistent in itself, and this for several reasons. First, it assumes that we can know ourselves and our deepest values in absolute transparency. Louise's case illustrates that this is clearly an illusion. Second, it also wrongly suggests that we can be a self in isolation of the social world and our relation to other people. And third, it suggests that the self is stable and at some point finished, and herewith denies change and development. In my view, if at all we accept authenticity as a touchstone or criterion to judge whether a decision is good enough to be respected as being truly my decision, this notion needs to be defined more loosely. And my suggestion would be to define it in terms of credibility and recognizability in relation to a person's level of awareness and self-appreciation, that is to say, step one in the Ask Me approach, while at the same time acknowledging that ourselves are always open to change and development as we adapt to new, often unanticipated situations. In view of this pragmatic definition, I can live with Anne's decision, but I would seriously doubt Louise's adherence to the Advanced Directive. Thank you for your attention.